Hi, and welcome to the August 2026 DermSurgery Digest podcast. I'm the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Spotlight podcast focused on Mohs, cancer, and reconstruction, we have Sydney Proffer, a private practice Mohs surgeon in Austin, Texas, doing the in-depth article summaries of key articles, and Erica Lee, Associate Director of Mohs Surgery at Memorial Sloan Kettering Hospital, as the Senior Expert Editor with commentaries. Don't forget that we will continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery, but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic-focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Welcome, listeners, to the DermSurgery Digest podcast. My name is Sydney Proffer, and I am your host for the August Dermatologic Surgery, Surgical Oncology and Reconstruction Spotlight episode. Today, it is my pleasure to introduce Dr. Erica Lee as our guest expert. Dr. Lee is a board-certified dermatologist and fellowship-trained Mohs surgeon and is Associate Director of Mohs Micrographic Surgery and Dermatologic Surgery at Memorial Sloan Kettering Cancer Center. In addition to her clinical leadership and mentorship, Dr. Lee is an internationally recognized researcher whose work has advanced our understanding of patient-reported outcomes and quality of life after skin cancer surgery. She has authored more than 100 peer-reviewed publications and has been consistently recognized by Castle Connolly as one of America's top doctors year after year. Dr. Lee, thank you so much for joining us.
Thanks, Sydney, for having me. I'm excited to do this together.
Perfect. Our first article we will cover today is titled Surgical Anatomy of the Genital and Inguinal Regions for the Dermatologic Surgeon, Landmarks, Danger Zones, and Perioperative Considerations by first author George Jiha and senior authors Benjamin Kelly and Stan Tolkachev. We will also be discussing the accompanying commentary by author Dr. Nahid Vital. Genital and inguinal skin cancers are uncommon but present unique challenges to dermatologic surgeons because of their complex anatomy, higher rates of advanced presentation, and the need to preserve function and cosmesis. This review article provides Mohs surgeons with a practical, anatomy-based guide to safely managing these tumors using Mohs micrographic surgery, emphasizing tissue-sparing techniques, critical surgical landmarks, and thoughtful reconstruction. Key operative principles include meticulous preoperative planning, accurate specimen orientation, and a thorough understanding of safe dissection planes. For penile surgery specifically, remaining superficial to buccal fascia protects the dorsal neurovascular bundle and urethra, while in vulvar surgery, avoiding aggressive dissection near the clitoris preserves sexual function and sensation. In the groin, respecting Scarpa's fascia is essential to prevent injury to the femoral vessels and nerve. This review also discusses reconstructive options, including secondary intention healing, primary closure, local flaps, and skin grafts, and highlights strategies to minimize complications such as contracture, wound dehiscence, and functional impairment. The authors overall conclude that as evidence supporting Mohs for anogenital malignancies continues to grow, dermatologic surgeons will increasingly encounter these types of cases. Mastery of regional anatomy, awareness of danger zones, and multidisciplinary collaboration when appropriate are essential for achieving optimal oncologic, functional, and cosmetic outcomes. In addition, the additional commentary by Dr. Nahid Vital talks about building on practical surgical roadmap outlined in this article by Jiha and colleagues. Her commentary reinforces that success in anogenital Mohs surgery extends beyond knowing the anatomy. It requires technical humility, multidisciplinary collaboration, and the recognition of profound functional and psychosocial consequences. Dr. Vital emphasizes that even minor technical errors can result in lifelong morbidity. She expands on several practical pearls from the review, noting the importance of patient positioning, gentle tissue handling under local anesthesia, and using suture rather than ink for Mohs mapping because of anesthetic distortion, which can make orientation unreliable. A major theme is the need for greater education in female anogenital anatomy, which has historically been underrepresented in medical training. She also reminds surgeons that anatomy changes substantially with age, hormonal status, and prior surgery, requiring individualized operative planning. Perhaps the strongest message is knowing both the value and limits of Mohs surgery. Dr. Vital concludes that by advocating for improved reimbursement in the field reflects the extraordinary complexity, time, and expertise required for these cases, while encouraging Mohs surgeons to seek cross-disciplinary training and mentorship, as these anogenital oncologic surgery becomes increasingly important part of our dermatologic practice. Dr. Lee, how much of your practice includes Mohs surgery in the genital regions, and what do you think of these pearls from these articles and the associated commentary?
So I thought, like you said, this article was a really excellent review of everything you really need to keep in mind when you're in this area. Similar to what we know, it is rare. So we're not seeing these tumors obviously as much as the more common ones we see in different anatomic locations. But when you do see them, I definitely feel there's a big role for most surgeons in really providing tissue sparing and preserving function. So, a lot of what we see, and a lot of what is seen in my practice is that if we have these cases, especially if they are on a male, for example, depending on where they are, like anatomically, if they're on, for example, the glans penis, like it's really important to make sure you're sort of pairing up with a urologist. And I like how Dr. Vidal also sort of mentioned that you have to take a step back, and there is a lot of humility that you have to have with these cases, because you want to be delicate. You want to make sure that if you are in certain areas, you might need like a catheter, a Foley catheter placed in advance. So oftentimes, we work with the urologist to make sure that's done. And then if there is going to be anything tracking down the urethra, and it comes to the reconstruction, we also often tag team with the urologist and they will do the reconstruction, because at the end of the day, we have to make sure that the function is preserved as best as possible. And you have to be humble and realize that that is their specialty. And we want to make sure we work with them as well. I also think whenever you're working in any of these planes, the tissue is really delicate. And I love the idea of using a suture or sometimes even inking it before you take it off and you finish the layer. Because the tissue is so delicate, it can rip, you can lose the orientation, it can sort of contract, and then you kind of forget where you are, or, what exactly might be your 12 o'clock, for example. And then I always sort of advise, or when we train, like you got to be very delicate with your undermining. Like you don't want to do like the extensive undermining that you may do in other anatomic locations, because you have such sensitive vascular structures and you also have a lot of nerves in that area. So, whenever we take these patients, you also have to make sure you're positioning, making sure there's a different level of comfort and the patient has to feel very secure and comfortable with what you're doing. But everything that's there in the review article, I say that if you are going to be doing a lot of these cases, you have to be really sure of the anatomy, and never feel intimidated at going to your colleagues, for example, and working with them, because at the end, you want to make sure you preserve as much function and quality of life for these patients.
Yeah, I agree 100%. And I would encourage our listeners to really review this article in detail, because I think, like you said, it talks very detailed about certain anatomic planes, as well as, like you said, when you were talking about working, especially on the penile shaft or towards the glans penis, making sure that you have that urethra in place. You don't want to do any type of local flap or any circumferential
Right.
type closure that's going to cause contracture. For women especially, I agree with Dr. Vital. I think historically female anatomy is a little bit underrepresented in medical training, so I like that she highlighted that. And then, like you said, especially being careful of dissection planes when there's so many sensory nerves in those areas will help preserve patient sensation after surgery. So I think it's a great article.
Totally agree.
Moving on to our next article, the next one we will talk about today is called The Safety of Perioperative Liposomal Bupivacaine Injections in Dermatologic Surgery Patients by first author Melissa Rams and senior author Nahid Vital. Postoperative pain after Mohs surgery is typically mild, but patients undergoing large reconstructions, flap repairs, or surgery in high-risk anatomic sites may benefit from longer-lasting analgesia. This retrospective study by Mayo Clinic evaluated the safety of liposomal bupivacaine, also known as Exparel, a long-lasting anesthetic that provides analgesia for up to 72 hours in 136 dermatologic surgery cases, including 48 Mohs procedures. The primary concern with bupivacaine is local anesthetic systemic toxicity, a rare but potentially life-threatening complication affecting the central nervous system and cardiovascular systems. Among 136 administrations, no cases of toxicity in this study were observed. The recommended infiltration technique for linear closures and flaps in this study include approximately 5 to 10 milliliters total per centimeter of incision. For very large flaps, the authors dilute 1 to 2 or 1 to 4 with normal saline while keeping the total dose of bupivacaine less than 266 milligrams, which is the max FDA-approved dosage for infiltration. For large hidradenitis or extensive wounds or surgeries, dilution up to 1 to 14 or 20 milliliters of Exparel plus 260 milliliters of saline was used. In the study, 2 patients experienced postoperative nausea while both taking tramadol, suggesting that the adverse event was likely opioid-related rather than attributable to liposomal bupivacaine. The authors in this study also provide practical guidance for Mohs surgeons. They recommend reserving liposomal bupivacaine for the end of complex procedures, waiting at least 20 minutes after standard local anesthetic injection before administration, and avoiding additional local anesthetics for 96 hours afterward. While prospective studies are still needed to define efficacy and the optimal patient selection, this series suggests liposomal bupivacaine is a safe adjuvant treatment for postoperative pain when used within FDA dosing guidelines and with careful monitoring. Dr. Lee, do you use bupivacaine in your practice? And if so, how do you use it?
So I think pain management, for example, is really important because, it really affects how the patient experiences with the procedure. So it's really important to figure out like what's best in your practice. So I just wanted to point out, I do use bupivacaine in my practice, but this is liposomal bupivacaine, and this is a sustained release. So it's actually encased in these microscopic fat particles that allows the bupivacaine to be slowly released over 72 hours. I don't use the liposomal, but we have the standard Marcaine, which is the immediate release bupivacaine. It's the bupivacaine hydrochloride, and that duration of action is usually about 6 to 24 hours. So there is a slight difference, and I just want to make sure the readers understand between liposomal versus the standard immediate release bupivacaine. So when I use the bupivacaine, I use it in certain scenarios. For example, if I have a patient who is going multiple stages and it's becoming a large defect, I know that every time I go back in, for example, that if they're having a difficult time numbing, or when we're going back for stages and they're having a lot of pain, then I will, after my layer, supplement with bupivacaine, right? Because I know they're going to be waiting for another hour. It's going to extend the duration. I also like to use it in patients who are getting a delayed closure. So if they're going to be seeing my plastics colleagues 4 hours later and they're going to get re-anesthetized, that can also kind of impact, they're nervous about the anesthesia again. It sort of impacts their experience. So we will always supplement with bupivacaine, only about 1 to 2 mLs. Like we don't give them a whole lot of it. And that just allows them to extend the duration of the anesthetic and makes it more comfortable for them. I also like to use it on patients who they just, metabolize the lidocaine really fast. Like you're injecting them and shortly after you're giving them a lot more. So as soon as a patient is like that, then anytime they have to wait, we will supplement it with bupivacaine. Or, if it's a large flap and I think they're going to have a lot of post-op pain or they can't get their medication sooner, then I will supplement it. But again, we don't give a lot. I would give, 2 mLs 1 to 2 mLs, because we're also, per flap, because you actually have to keep in mind that you've given them a lot of lidocaine. So I tend to do bupivacaine for that. And I also love to use them in my digital blocks. So if I'm going to do, so if I'm going to actually do Mohs on a digit and I'm going to do a digital block, I will take the lidocaine, 1 or 2% lido, and I will mix it 1-to-1 with the bupivacaine because it doesn't have epi, and the duration of the of the anesthetic for the digital block lasts the entire day for most. So that really works well for me. So I do that a lot. And my last thing I wanted to sort of mention with this study is that the cost, if you actually look up, because I was curious on the cost of liposomal bupivacaine, and it costs hundreds of dollars. So you really have to keep that in mind. When you are thinking about using it, just make sure you have it or you have like the funds or the ability to get it. And if you are going to use the standard Marcaine, it really is just a few dollars per vial. So you are getting a very different experience, of course. And the liposomal is great because it has a long duration. But if you anticipate you might have, you always want to keep in mind that if you ever are going to have a hematoma and you needed to do something, you really can't anesthetize them again for 96 hours.
Right.
Right. So those
I
are
have
just little, caveats that you kind of need to keep in mind. But I think it's great that if there are different options for physicians and for surgeons to use different um, medications to at least to avoid like an opioid. So this is a good study, but just to keep those little caveats in mind that this is the liposomal variant and it's a very different cost. And you do have to make sure that I would never try to go, I would limit how much to use. I would never try to go to the max of it,
Right,
the max
absolutely.
dosage.
I use similar to you. I use regular, the more immediate release Marcaine in my practice for similar type patients, larger flaps, having
Yeah.
a lower pain threshold. They're really going to struggle with anesthetic during the day. I have not tried it for the digital block, so I think that's an excellent pearl for our listeners, and I can't wait to try that in my practice. So
It works really well. Like it lasts the entire day until they go home. And when you go home, it's really painful in a digital block. You have to elevate it. But if you use the Marcaine, it really helps them get through the next 24 hours. And it is, I do it for every digital block now. So give
okay,
it a
I love
try.
it. I think that's a great practical pearl. Okay, great. Well, those were excellent tips.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendars out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
We're going to move on to our next article, which is a novel transcutaneous suturing technique with microsurgical assistance for excision of small facial nevi, a retrospective comparative analysis by first author Haedong Lee and senior author Quinlin Wee. Among small facial nevi that are less than 2 millimeters, they are commonly treated with laser, electrocautery, cryotherapy, and surgical excision. Among these, carbon dioxide or CO2 laser is widely used in the treatment of benign skin lesions due to its simplicity, speed, and nearly bloodless application. However, laser ablation is a blind procedure that cannot provide histopathologic analysis and carries the risk of incomplete removal, recurrence, and thermal scarring. In this retrospective study of 60 patients, investigators compared a novel microscopic assisted excision with transcutaneous microsuturing to CO2 laser for cosmetically sensitive facial nevi. The microsurgical techniques use 5 times magnification with complete excision followed by a unique 6.0 or 7.0 PDS transcutaneous dermal suture aligned to precisely align the wound edges. I encourage the listeners to review the step-by-step instructions and subsequent photographs in this article for additional suture explanation. This surgery required slightly longer operative time, or 3.5 versus 3.8 minutes, but resulted in minimal bleeding and significantly outperformed laser in every clinically meaningful outcome. 6-month Vancouver Scar Scale scores were dramatically lower, and patient satisfaction was higher at 9.2 versus 7.1. Recurrence was also reduced from 30% after laser to just 3.3 following excision. Importantly, surgical excision also provided tissue for histopathologic confirmation, an advantage unavailable with laser ablation. For dermatologic surgeons, the take-home message is that meticulous surgical technique, not simply lesion removal, drives long-term cosmetic success. Microscope-assisted wound edge approximation, dermal tension redistribution, and avoidance of epidermal implantation may produce nearly imperceptible scars. The trade-off is the increased technical complexity, operative time, and cost. These encouraging findings should be interpreted cautiously given the study's retrospective design, small sample size, and single center experience, but they reinforce that precise surgery remains the gold standard. Dr. Lee, what do you think of this technique, and have you ever used something similar?
So I watched the video a couple of times, and I thought it was a very cute technique. I just wanted to point out that the lesions that they removed were tiny. They were 2 millimeters or smaller. So it makes, when they say the microsurgical assistance, you do need some sort of, I think, either magnification or you have to be able, either have really good close-up vision, or it sounds like they use
Yes.
like 5X, like surgical loops, to visualize it better. It's, in my mind, this is sort of a principle that we've learned in surgery and in Mohs, that the best cosmetic outcome or really is how you place the sutures. Like you want to make sure you maximize eversion when possible, and you want to reduce the tension on the wound because scars contract. And if you don't have good eversion, then you can lead to a more noticeable scar. So essentially what it sounds, they're doing sort of like a modified, kind of like a very like vertical mattress type suture. It's a few more, passes through. I thought the way that it's hidden away, it's cute. Like you go a couple of passes and you were able to sort of tuck the stitches in. You can't see it. They're using a PDS, which lasts much longer. It's a very, very small PDS because it's a 6 and a 7. I don't have a 6 and a 7 for PDS. I don't even know if I have like a 6.0 monochrome, but I think you can use something similar like that and give it a try. But I think that the core principle, similar to what you said, is that you really want to suture because you're really promoting like a horizontal mattress. You're just sort of burying it and not removing it and just avoiding epidermal sutures. So in that sense, it is a good technique. I think it's more applicable maybe if you do a facial biopsy, like maybe like a punch biopsy. This might be a good technique to sort of really, really get the best eversion and cosmetic outcome that you can for sort of like a punch biopsy. I don't see it as much in Mohs that we might be using it because, we'll do good eversion, we'll do mattresses. But because these were small facial nevi, I see the desire to make something very imperceptible on the face. So again, like similar to what you said, it's a very small study, but it's worth trying. I think if you do a lot of facial punch biopsies, patients are so concerned about the scarring, and that's one of the most biggest concerns they have with even doing a biopsy. But if you can sort of show them that you're gonna tuck the scar, tuck the stitch in, they won't see it, it's solvable, they don't have to come back, and you're really, really trying to get the maximum version, then I think it's a great thing to try.
Yeah, I agree. I have a lot of patients who come in and they want cosmetic mole removal on their face, and they
Yeah.
don't realize that the best option truly to fully get rid of that mole is to surgically excise that. Again, I think your point about this being a very, very small study as well as very small nevi
Yeah.
is important because obviously the larger the mole is on the face that you're excising, a single 6.0 or 7.0 PDS I don't think would be appropriate for like an 8 millimeter facial
That's a
nevus
great
that you're
point.
doing.
Yeah.
So I agree. I think it's a very interesting technique. I encourage the listeners to read the article, look at the photos, watch the video, and definitely something I'll try, but not as applicable, I think, for the larger facial nevi that you mentioned. Perfect. Okay, so our final spotlight article is called Nail Splints to Prevent Dorsal Pterygium After Nail Surgery, Indications and Optimal Selection by first author Kimberly Ken and senior author Adam Rubin. Dorsal pterygium is an uncommon but potentially devastating complication of nail surgery that occurs when the proximal nail fold adheres to the exposed nail matrix or nail bed after trauma or surgery, leading to permanent scarring, possibly a split nail deformity, or complete loss of nail growth. This review provides a practical framework for preventing this complication through thoughtful use of nail splints following procedures involving the proximal nail matrix, proximal nail bed, or proximal nail fold. The key message for dermatologic surgeons is that not every nail procedure requires splinting. Routine nail avulsions and small distal or lateral matrix biopsies generally carry low risk, whereas proximal matrix biopsies, tumor matrix extirpation, Seymour fractures, and any procedure opposing dermal surfaces should routinely receive a splint. The native nail plate remains the ideal splint because it perfectly restores the natural contour and rigidity. When unavailable, however, such as after pathology submission, numerous synthetic alternatives are described, including silicone sheets, aspiration or nasogastric tubing, polypropylene suture relay packs, and proprietary nail splints are inexpensive clinic materials such as Xeroform or sterile surgical gloves. Material selection should balance the rigidity, ease of shaping, drainage capacity, and sterility, as well as availability. The authors provide practical operative pearls. Splints should be advanced fully beneath the proximal nail fold, secured without passing sutures through the nail matrix, and typically left in place for 2 to 3 weeks using absorbable or non-absorbable fixation depending on the need for stability. Although comparative evidence remains limited, available studies show that replacing the native nail or using appropriate splint reduces postoperative pain and decreases nail deformity. The take-home message is simple, that whenever surgery exposes the proximal nail matrix or nail fold, maintaining the nail sulcus with an appropriate splint should be considered in an otherwise difficult to correct complication. Dr. Lee, how often do you perform nail surgeries, and have you ever used one of these splints to prevent a dorsal pterygium?
So I do a lot of nail surgeries. I have never used a splint, but now I think I should have. So it's interesting. My practice has evolved over the past several years. When I first started, and every time I did a nail matrix biopsy or I would do Mohs, I would initially start by removing the entire nail plate. Right. So that was how I was trained initially, and that's what I did. But I did have, a handful, 1 or 2 patients who did develop a pterygium, right? And it's sort of one of those things that once you develop it, it's extremely hard and you can't really correct it. And they're okay with it eventually, but it's just unfortunate that that happened. But as practice has evolved, I stopped doing that. I try to preserve the nail plate as much as possible. And if I'm even able to do a biopsy and replace the nail plate, like lift it and replace it, because it heals much better. It's better for pain management, and similar to what the authors have shown here, it prevents the pterygium. So even for most cases, I think it also, not only for the post-op pain, for the pterygium formation, but even for tissue processing, like I keep the nail plate in. But if I were to lose the entire nail plate, I think they did a great job in providing lots of different options because, when you think about a splint, you kind of think you have to buy something that's designated for the nail. But there seems to be so many different options. Again, I think something that's sort of pliable and that can sort of adjust and not have any sharp edges is probably the best way to go. Xeroform is a good option if you can get it underneath that area, as long as there is nothing, as long as the proximal nail fold is not touching in contact with the nail matrix or the nail bed, it will prevent this from happening. So I think you can use anything from Xeroform. I like the tubing idea. They had so many different options in there. So I do feel that if that is a scenario where you have lost a nail plate in that area, that putting that in there makes a lot of sense, and it will really prevent something long term. And the 2 to 3 weeks sounds perfect because we often see patients back around that time, and then you can remove it at that moment. So I haven't actually made a splint, but this makes me want to make one for the next one.
Yeah, I agree. I think this
What do you
so
do?
I have seen it done twice in my fellowship training, and I think they're underutilized and underthought about, but I think preventing that long-term complication of pterygium is amazing. And if you can think ahead long enough to be able to prevent that and use something as simple as like even the foil from the suture packet, if you can kind of tie that
Right.
in. Something as easy as that. I like Xeroform a lot. I've seen it once with the foil from the suture packet and then once with Xeroform. And patients actually, they really doesn't bother them as much as you think it would, as long as you don't have those sharp edges and it's kind of malleable. And it
Yeah.
worked out great in my limited 2 cases anecdotal evidence. But I think this is a great article and definitely something we should incorporate more in our practice.
Yeah, I don't think you really think about that. You often, like, I don't, this makes you also want to counsel patients differently, like, letting them know that's a complication if that happens. Because you tend to think about more nail deformity, nail plate deformity, right? So they may not have the nail plate there. It might become loose or it might be a little bit thicker. And you go over all the different types of nail plate deformities that can happen as sort of the risks of surgery in that area. But this is something else to keep in mind and also counsel the patient on.
Perfect. Well, Dr. Lee, thank you so much for sharing your expertise and helping us navigate these important advances in derm surgery. To our listeners, you can visit asds.net/dermsurgery-digest for more journal podcast content. We hope you'll join us again next month as we continue to explore the latest evidence in derm surgery.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.